all about left main and bifurcation lesions. So to start off, I would like to introduce Dr. Yuk Kung Kyong from the National Heart Center from Singapore. He's been a good friend. He's been involved in Singapore Life, and he's going to discuss with us with regards to the polymer free drug-eluting stent, the CREATE. KK?
Thanks very much, Rosley and Eric. I'm going to have to share my screen, so I'm going to take over the screen for now. I believe you all can see my slide. So the title of my talk is on the polymer-free drug-eluting stent, CREATE. And I think this slide here shows well the unique structures that form the CREATE stent. The stents here you can see has no polymer. It has wells which drugs are embedded in the abluminal side, and you can see that it has a homogeneous scaffolding and good side branch accessibility, which I will show in a while. And the stent is made of cobalt chromium with stent struts between 70 to 80 microns depending on the particular stent size. I don't think we would have time to go through all the characteristics of the CREATE stent platform. I want to highlight a few things that are relevant to today's session on left main and bifurcation. So the first is that it has a homogeneous scaffolding and has got good side branch accessibility. I find it hard to pronounce the word branchability, which is certainly a new word for me. And this is just a description of the difference in the maximum unprotected circular area between the stent struts of the different stent platforms. And you can see here for the CREATE Evo platform that there's a good MUCA, which is 1.3 millimeters. And moving on, if you look at the side branch access, the number of cells per diameter per circumference in the middle column here, where my arrow is, you can see it can range from 3 to 4 cells depending on the nominal diameter of the stent, as well as the strut thickness. The maximum cell expansion is pretty significant and large for these different stents. For example, for the 3.5 to 4.5 millimeter stent sizes, you can go up to 4 millimeter for side branch access, which is important because if you do left main bifurcation interventions, that is really an important consideration. This is up to this slide here shows the post-dilatation maximum diameter, and you can see that for the 3.5 to 4.5 millimeter stents, you can go up to 5 millimeter in terms of a maximum diameter, which is of course very, very useful in left main bifurcation interventions, as you will see in a short while's time. Now, the next part that I want to share is this particular series of slides published in Eurointervention. Nick Foyne used to be at Heart Center as well. You can see that if you use a provisional simple stenting without post balloon dilatation kissing, you would have stent struts crossing the orifice of the side branch. If you do final kissing balloon inflation, you may have some deformation with some stent struts not well opposed. This slide here shows potential different areas for side branch crossing. But what I really like is this slide here, which shows the differences in how the stents can be deformed if you have side branch crossing at different locations. For example, if you cross in say, for example, in the distal edge and you don't protect the main branch, you can have significant deformation of the main branch and the stent in such a scenario. So the CREATE platform has the ability to make sure that with the side branch access, you minimize the degree of deformation of the stent, as shown in this particular 3.0 CREATE stent, which after kissing optimization appears to have very little disruption of the stent. Further examples as shown in this on-table testing, if you have a 3.0 CREATE post-dilated to 5, you can see that the stent struts are reasonably well expanded and there is limited deformation of the stent, and even a 4.0 post-dilated to a 6.0 has a very good structural integrity. The second part about the CREATE stent platform is the Abluminal reservoir technology, and it is the basis by which they can remain polymer free, because you can have abluminal drug release with controlled drug elution without having to to use a polymer. So in that sense, that's good. And they have other research as to how this will not be destroyed by, say, shockwave and whatnot, which I won't show. Suffice to say that this platform allows for drugs to be delivered without the use of a polymer. So that is, I think, an advantage. Now, I think it's very boring to talk about just all these data. I mean, I sound like a commercial. So I thought it'd be nice to show a case where I used the Create Stent platform. This is a 76-year-old gentleman who presented with a high-risk non-ST elevation MI. His ejection fraction is moderately impaired at 40%. And of course, in the worst kind of cases, he has end-stage renal failure, diabetes, the whole works. And for a variety of reasons, he was felt to be high risk for bypass, largely because of this slide here. You can appreciate on the left side that this patient has a heavy calcium, and he's also obviously hemodynamically impaired with the presence of a balloon pump. On the right side of the screen, I'm sure you can appreciate the type proximal LAD stenosis, as well as the mid-LAD disease beyond some previous stent with in-stent restenosis. The next slide here shows the severe ostial circumflex disease, as well as proximal to mid disease in the circumflex. And I think all of you can appreciate on the right panel the severe disease in the ostial LAD and the ostial circ. So this case came to me, and I thought that the best way to treat such heavy calcium was rotational atherectomy. And this is just a simple 125 burr. I'm sure many of the experts listening in and on the panel would agree that this obviously is not a big burr. But I just wanted to clear a path to enhance expansion. And the next slide here shows what happens with the first burr. There's obviously a track, and obviously that's not good enough. So we went out with a 1.5 burr to do more rotational atherectomy. This is after rotational atherectomy. And this patient kept moving during the procedure, which really made my life difficult. So you have to forgive some of the jerky motions on my videos. Now I have a steel frame, not a steel frame, but a frame without contrast on the right side to show that the wire that is left in the circumflex has substantial space between the origin of the circumflex from the LAD. And without the use of Dynaglide, I was able to advance another burr into the LAD. So of course, this is off-label use and not generally encouraged for rotational atherectomy to do it with another wire in place. But the reason I did so was because I was really quite afraid of losing access in the circumflex. So here we demonstrate on the left panel that the rotor burr is separated clearly from the first wire, and then we proceeded to do rotational atherectomy on the right side very, very carefully, as you can see here. So we did rotablade on both vessels, and then we proceeded to do more pre-treatment. We used the angiosculpt in this case, a trio by 15. And then we further treated the LAD. You can appreciate that the LAD has a waist in the vessel. We proceeded to do more pre-treatment, in this case a shock wave, and then use angiosculpt to pre-treat it even further. And then we used the DK crush technique to treat this lesion. It was kind of painful, but I think the benefit of using the Create is that it allows us to cross the stent struts easily. I'll show you that in a while. This is a Create 35 by 33 with a balloon going up in the LAD trio by 15. Now, just to illustrate that, we were, despite the Create, the first wire went in under the stent strut, which you can see on the right panel. Sorry, not under the stent, under the crush segment. So we were able to rewire through the stent strut fairly easily, like so, and then proceeded to do the rest of the DK crush, as you can see here. And this is a Create 35 by 26 in the LAD. And this is more kissing, and again crossing the vessel in the circumflex, into the circumflex. So kissing, and then potting with a 4O by 15, and then the 5O balloon. So these are the final results showing, I would say, a reasonable stent expansion. You can see that there is hardly any waste seen in the circumflex and in the left main. And I think this picture would say it all. I think we had very good stent expansion in the DK crush technique using the CREATE platform in this high-risk complex case. So I want to summarize by saying that the CREATE platform technology facilitates bifurcation interventions such as in this complex left main intervention. It offers excellent side branch access, and with the benefit of the unique polymer-free well-based amphilimous technology, it is a dry-eluting stent that I think is something we should all consider for such complex interventions. Thank you very much.
Okay, thank you very much. That was a nice introduction and on CREATE amphilimous, and also to follow up with the case. Before I think we've got some time. I think we should have time to discuss the case after every presentation. Please use the Q&A, where you can click and then ask questions. We will try to answer your questions. And in fact, if let's say after this you ask a question about the case that Dr. Yeo has presented, then he himself can actually answer that for you. So please make use of the Q&A. So I think that was a very well done case. I think it's a very high risk, case, and I agree with you. I would also start off with a small burr because I don't want anything to happen, and it's so much safer to make the channel open first and then plan on. But can I just ask you, with regards to your technique of double kissing crush, the circumflex seems to be a bigger vessel than the LED, and you could have actually used the 4O CREATE, and that would allow you to have a bit more safe in terms of post-dilatation with a bigger balloon in the left main, and you'll be quite secure to know that at least with regards to the limits was much better if you use 4.0 balloon stent for the left main. Was there any particular reason that you chose one or the other?
Well, I generally am a bit more paranoid about losing the LAD, and I thought that with the DK crush, I would generally prefer to protect and give priority to the LAD, because in my mind, it is a more important vessel. Of course, in this case, the circ is a huge vessel too. So to be honest, I did debate it a little bit, but I just stuck to my original, first principles, that I would generally preferentially protect the LAD above all. So that was just a bit of I think in this case, just one. I mean, one way would have done just as well. The other way would have done just as well.
Yeah. IVUS guided?
Yeah, I did do IVUS. I didn't show it. I had I think 40 slides. I know I went pretty fast. Coffee was kicking in finally after 12 hours. So I was a bit afraid that I'll go over time, so I didn't put the IVUS in this particular deck.
Anyone else? Yeah.
IVUS is important, I think, Rosalie, indeed. I think, but I think there's always almost a value of IVUS and left main, certainly to look also at the ostium of the circ. But to some extent, if you have used IVUS a lot, maybe it's a wrong statement. In your initial experience of left main stenting, you may get away without it. I'm not sure. It's a bit provocative, but there is probably some truth in that. I don't know what you think about it.
I did use IVUS. I just didn't show the run. So I did IVUS it, and I was just, this was one of those procedures that I was just scolding myself for taking so long, but I thought it was important, and I imaged left and right. And I remember my colleague who was supporting me with this case said, hey, you should finish off with an IVUS. So I did. It's just that I was afraid that I would go too long on this presentation. And the good thing is that I did post-dilate for 5.0. So we did maximize our pots to ensure that we have a good apposition.
That's true. On the other hand, IVUS takes you so it doesn't take much time at all. You can do an IVUS very quickly. It's so easy to perform, and definitely, for sure. Any other? We don't see any questions from the.
KK, maybe I can ask something about the you leaving the wire. It's, I mean, it's gutsy. I guess the question would be that how confident can you be that when you pull back your burr, will it somehow not just nip the wire and then engage it, and then next thing you know, the whole thing is swirling around?
So that's a good question. That's a very good question.
And the people have described putting in a guide liner to actually protect the wire and then putting a burr beyond it. I wonder if that is safer. I don't have any experience with either technique. I'm wondering what your thoughts are.
So I've done it with a guide liner as well, but you need a larger guide. For this, I think I use a 7 French, I think the key is to be careful not to dynaglide forward, but when you come out, there's usually not an issue because the back of the burr doesn't have diamonds. And I've done this maybe, I don't know, this would be my 4th or 5th case I've done it this way. And typically for these kind of left main bifurcation, so it's not something I want to do because it does make everybody a bit nervous. It's only when you have the concern about the risk of what you call losing the circumflex that would force me to do it. I maybe just so to highlight the fear, I will share the slide again, and I think maybe then I think y'all would appreciate my fear as well. So I think this is the slide. If you give me one moment, I will just flash it again. Can y'all see?
Yeah.
So I think this view doesn't show it as well. There was one other view which maybe I think this view would show that it was just hazy, and there was a lot of concern that I would lose access to this. The spider view showed the haziness a lot. So I think that was the main worry that we had when we decided to go with that. And I guess maybe because I've done it before, so I was a bit more confident that I could avoid that particular trouble. But you're right. I mean, we have read those case reports of using the guide liner, and I've done that using, as well, but not in the kissing fashion.
I mean, one alternative approach could be that, if you're so worried about losing the side branches, to actually stent the circumflex, crush the stent, and then go ahead and ablate the LAD. I mean, that's been described.
Sounds complicated.
Yeah, it is complicated, that's for sure.
Which do you use guiding 8 French or 7 French and a guide liner 5, or what would you need?
I think if I were to use a guide liner, it would be easier to have at least a 7 French system. And the guide liner has been reported to work, but the few times I've used it, it's gotten stuck. So I've used a telescope to greater success. So okay. I mean, we have heard different speakers talk about such the differences as well. So for me, I think the telescope has been more useful for such procedures. So at least 7 French, but the 7 French can only take up to 1.25 burr. I don't think it can take up to 1.5 burr. So if you want to do, with a 1.5 burr, I think it would be at least 8 French. So not as straightforward, I think.
Yeah, agree. So I think we should move on. And we've got 3 other speakers, and the next couple of the next 3 speakers will be discussing on a case approach, sharing with us their cases, and I think this will be on the with regards to create. And the first will be Dr. Chin Chiang, and Dr. Chin Chiang is from the National Heart Centre, Singapore. He's going to present precision left main bifurcation stenting using Create Evo. So Chiang.
That's great. Thanks, Dr. Rosalie. So let me just share my slides. Okay, I believe you will be able to see my slides now. Okay, so I'm going to share a case where I use the Create Evo drug-eluting stent to perform left main bifurcation stenting. It's remarkably similar to KK's case. But there are some minor differences. So my patient was a 40-year-old male, very young, with diabetes, hyperlipidemia, and he was a smoker as well. No cardiac history, but he presented this time with non-ST elevation MI. I'll show you the angiogram shortly, but essentially it showed triple vessel disease with very proximal or ostial LAD and circ lesions. Echo EF was 23%. So these are the angiographic pictures. You can see the LAD is very, very diffusely diseased all the way to the very distal apical LAD as well. And on the spider view, on the right side, you can see the disease starts in the very proximal ostial LAD. The ostium of the circ looks like there may be a bit of a landing zone, but there's a very early disease just after that ostium. So anyway, so these are the other views. Epicranial on the left, just to show the diseased LAD again, and the non-dominant right RCA on the right-hand side. So we referred him for bypass, obviously took him off the table and referred him for bypass, but he was deemed to be unsuitable for grafting because his LAD was too diffusely diseased. So then he was obviously sent back to us. And these were the considerations in his case. So this was, pretty much left main equivalent disease. Left main itself looked not too bad, but there was very early LAD and circ lesions. The left main itself was short, was a left dominant system, and the LAD was very diffusely diseased. So for this case, I was going to leave the right alone, obviously being non-dominant. And for the left main, I debated a few techniques, but I ultimately decided to do DK crush. Imaging with IVUS, and I will show some IVUS pictures. And with regards to the choice of devices, obviously we have to, for such a diffusely diseased case, we have to consider attributes like deliverability. He was a diabetic, so you want some good long-term results for him. And being a very slightly complex kind of left main with a very short left main, I thought a stent with markers might be helpful for landing the stents appropriately. So I started with IVUS of the circ. For this case, I wanted to know really whether there was any landing zone for this for the circ stent. This is the more distal of the two lesions here in the proximal LAD. This part here looks relatively normal. It's that island of normal vessel on the angiogram. And then you see the very tight lesion here. This is in the very proximal circ. And there's maybe a little bit of space before the LAD wire comes in from the 12 o'clock position. And the left main is short. So in summary, the IVUS showed that there was a short left main, obviously, as we already saw on the angio. The ostium of the circ didn't look too bad on its own, but it was very, very close. Or rather the lesion was very, very close to it. And then there was a further lesion a few millimeters away. So I felt like if I really wanted to try and nail the ostium, as they say, and if I failed, then I would be left hanging neither here nor there. So I decided to just go all out and do the two-stent bifurcation technique. So first I treated the diffuse LAD disease. I stented up to maybe the mid to distal area. I didn't want to treat further down in the distal LAD. So two stents from proximal to mid distal. And then this was what I was left with for the left main. So I pre-dilated with an NC balloon on both branches. It's the Radon 3 NC balloon, 3.0 millimeters on both. And then went ahead to position the first stent for the circ. So with IVUS guidance, it showed that the circ was about 3.0 to 3.5 in diameter. So I chose the 3.0 by 26 millimeter create EVO DES. I had marked the ostium of the left main with IVUS. So I kind of knew where to, how far back I could go with the circ stent. Positioned a 3.0 NC balloon in the left main to LAD. I guess you could argue I could have used a bigger balloon, but that's what I parked over there. And I deployed the circ left main to circ stent in this position before crushing it with the 3.0 balloon. This was one of my earlier cases of DK crush, and at that time I was still very afraid of the wire getting crushed and stuck. So that's why I removed the circ wire before crushing it. but these days I tend to leave the wire in. So this is what the angio looked like after the left main to circ stent and after crushing it. So this was the rewiring. I'm not sure if you can see on your screens, but you can just make out the proximal stent marker of the create, and not dissimilar to what KK showed. It was quite useful to have this stent marker when it came to rewiring the circ. So this was my first attempt. It went in, but as you can see, it seems to go underneath the stent marker. So I felt like it was going too proximal. Maybe even through the lumen, if you like, of the crushed stent. So I took that out and rewired it. This time I wasn't quite happy with the way the shape the wire was taking. I thought maybe I was going too distal this time. So I repositioned it finally, like so. A little bit more happy with this one. At this point, I did IVUS again. So this is IVUS pullback from the LAD to the left main across the crushed circ stent. So that's the crushed circumflex stent. You can see the wire peeking out. That part, it jumped a little bit, but I was satisfied that it had gone in perhaps through the middle of the stent. You can also make out that the stent from the circumflex just about protrudes a little bit into the aorta, not by much, but certainly it was right at the ostium of the left main. So I knew from that I couldn't stick out my LAD stent too far back. So then, having been satisfied with my wire positions, I went ahead to do the first kissing. This was with a 3.0 NC balloon in the circ and a 3.5 in the LAD. And then position the LAD to left main to LAD stent. So this is the LAO cranial projection. Again, very helpful to have the marker from the circumflex stent. To know where not to, or rather to know how far back I can or cannot afford to go. So I deployed the left main to LAD stent in this position. That's what it looked like after. Did a post-dilatation of the left main stent with a 3.5 NC balloon, rewired the circ and again confirmed it on IVUS, and then did a final kissing with a 3.0 and 3.5. These are the final IVUS images from the proximal circumflex, proximal LAD on the left to the left main and proximal circumflex to the left main on the right. Looked pretty reasonable, and of note, the stents did not protrude too far out into the aorta. So that's the stent just protruding a little bit on one aspect of the vessel into the aorta. You see the final angiographic pictures. The distal doesn't look very healthy, but I felt that was the best I could do. And the left main bifurcation looks not too bad on the circumflex shots. So in summary, complex left main bifurcation PCI can be successfully accomplished, obviously with careful pre-procedural planning. Intravascular imaging, as we already heard from the panelists, really facilitates complex PCI, especially left main bifurcation interventions. And the choice of stent for complex PCI is an important consideration. The Create EVO DES offers obviously better outcomes in diabetics, improved deliverability over the older platform. And the stent markers, I think in this case, were really quite helpful and useful to allow us to position our stents precisely. Thank you.
Thank you very much, Yang. So are there any, once again, I would like to encourage the participants to please submit the questions, put a key online because we don't have any questions yet from all of you. So please do key in your questions. So any feedback or, any views from the panelists?
Sorry.
Yep, carry it, Eric.
Okay, I think the case is brilliant because it really shows certainly to our younger colleagues how to approach stepwise very creatively, I would say, to already take into account the title of Fahim. But it's very nice, and also the approach showing the advantage of having the marker and entering into the circ more distally is very nicely illustrated. So congratulations on this. Keep things simple, even when it's complicated, like in this approach. So I really I like this a lot. That's a personal opinion.
Thanks.
Any other comments?
Yep. Fahim?
Chang, that's a great case. I mean, and I think you're echoing something that hopefully I'll also show, where the markers are really helpful. Just a question: that have you noticed that you can, the extent of your crush, you can actually almost make your crush relatively limited. You can almost get a micro crush because of the markers. That's something that I've noticed a couple of times, or more than a few times with Create. I'm wondering what your thoughts are on that.
Yeah, I think that's a good point. I guess the less crush you can achieve, the better. Right. This was one of my first few attempts at DK crush, so I erred on the side of safety rather than leaving myself hanging. So yeah, but yeah, I guess that's a good point, and I think you're right. If you have the stent markers to maybe guide you in the deployment, that can help you reduce the amount that you stick out of the side branch.
So let me maybe ask a question to the whole panel here in a practical setting, because of course we want to keep this as minimal as possible. Because imagine you miss the ostium the circ, which probably happens. So what would be the advice of the group here to the attendants? Do you just put a second stent more proximal because anyway we are here using fringe thread technology, or do you have to shift technique? What are your thoughts on that?
I think if you've missed a lot, then I think it's probably okay to put a second stent. But if it's like a rim, I would probably blow up a drug-coated balloon there and hope for the best.
So then you would convert to a kind of awkward T stenting?
Kind of. And that's what it'll end up being, which is awkward, as you said. Yeah.
Because of course the circumflex ostium is the Achilles heel of left main PCI. Huh? That's something that we should recognize. Huh?
Years ago, I had one case where actually I know I missed a rim of the ostium when I, expanded a appropriate sized drug-coated balloon there, and that patient has done well for now years. Of course, I haven't re-imaged him, so I don't know what his actual angiogram looks like.
We are rather keen to not bother too much about the overlap, because anyway we are using, these are not the stents we used 10 years ago, so we probably think it's not that much of an issue. But of course,
I mean, one of the things that I tend to do personally, I mean, not for the miss circ, but with regards to stenting, from the IVUS, it looked as if the circumflex about 3.5. You choose a 3.0. I think that's an acceptable, decision. But I tend to pull back a bit and go very high pressure. And at least it's quite safe that with the Create balloon, you can actually go up to about 24 atmospheres. And most times or not, it'll be all right. So at least you make sure that you get the stent well expanded, and it'll make it so much easier subsequently to pass in a balloon expanded. So at least for the audience sake, you know that this is a balloon that is a bit more forgiving in terms of wanting to take much higher pressure than the normal other stent balloons.
Maybe going back to Fahim again, I know that in Asia you're not that much concerned of mingling up DEB and DES. You're quite okay with that?
Yeah, I mean, we haven't had any issues with even deploying a drug-coated balloon and then ending up having to stent it with a drug-eluting stent.
Do you stay then in the Lemus family, or you don't mind you to have?
No, we initially did, but now we really don't give it too much of a second thought, and anecdotally have not had much of an issue.
Hey, talking about the Lemus family, right? Can I ask, everyone in the panel, how does it work for? Is it even more effective in end-stage renal failure or CKD patients? And we know that, of course, it's a technology that has benefits in diabetic patients. But what about in renal failure patients, do we have any data on its any additional benefits in renal failure patients?
I don't have any info. The only thing I remember is that last year at Sing Life there was a poster from your hospital on unstaged renal patients on dialysis, where the outcome, if you perform PCI, is terrible, very bad.
Yeah,
I picked up this thing, and it's something that hasn't been studied extensively. But it would be interesting to look at that, because it doesn't seem so complicated to gather this data.
Hey, there's an interesting question on the Q&A. I like this question a lot, but maybe Rosli or Eric can look at it.
Okay, so we'll just take this question first, before we go on to the next speaker. So the question is that there are different stents, especially for left main stent bifurcation. What stents would you recommend? So in your own personal practice. So I'm going to ask very short. Fahim, you first.
What stent for? Sorry, I didn't look at
bifurcation. There's Onyx, there's Synergy, there's Create. What would you choose?
I think that honestly, for me, all the modern drug-eluting stents are pretty much the same. I'll go by sizing. I'll go by what can grow appropriately for the vessel size. I think that's the key factor for me. The rest, I think it's kind of they all have some fine points, but they're all pretty much the same.
All right, Chiang.
I think like Fahim says, in terms of outcomes, they're all probably quite comparable, to be honest. In this case, I chose to Create because I thought I'd use the markers to help me. If it was a more angulated circ, I might choose a different kind of stent. So I think it kind of does depend on what the left main looks like to an extent.
Yeah. KK?
I think I agree with Fahim and Chiang. I think the question is asked, of course, knowing that all of us have been in different webinars before. So I think it's a fair one. We have spoken for other companies as well. But I do think that knowing the structure of the stents help. I give you the example for the Create. The large stent struts tell me that I can do it, and I think the markers are unique advantage. Now, I don't always use the Create. I've used Synergies, I've used Onyxes, I've used whatever for all. I mean, one example that I might choose differently is if I have a ginormous left main, I might choose a stent that has an even better expansion profile. Or if, let's say, I've already had Zion's re-stenose on me, I might choose a different stent. So I think there is no right or wrong, to be honest, but knowing the stents and how it might work for that case does help you. There are some stents that I wouldn't use, and out of courtesy, I wouldn't mention these stents because of other reasons, but the modern stents, frankly, do very well in this setting, as long as you choose them specific for the case. So I think that's probably a reasonable way of approaching it.
Yeah. Watson?
I think everyone has been very diplomatic. Yeah, so I would choose the same path as well. I think for me, it's the stent extendability. Yeah, the amount of stents that the stents that can extend to fit the normal size of a left main would be my main considerations. Yeah, so you need to know your stents. So whatever stents you're comfortable with the new stents, please go ahead, I think.
Eric, your final is yours.
Last but not least, sorry. No, I think all has been said very wisely. I think we don't have to be diplomatic. I fully agree. But we all know that the majority of modern stents do. There are indeed some stents, I fully agree, that maybe not the right thing to choose. The advantage of Create is the marker, and once again, and the fact that the stent is quite visible compared to some stents that are almost not visible. Some stents that come from Germany, for example, that are quite flexible to be known. The most important is probably not to undersize, if you stent from left main to LAD, your left main to LAD stent, because you have to know very well the properties and the expansion properties of your stent. So use the stent you're used to work with, but certainly know the device you're using. If you're flying this airplane, you should know how this airplane works.
All right. So to summarize, it's just the expansions, stent expansion, the side branch access, Of course, in this case, Marcus would definitely help give some assistance in your stenting. So thank you very much. So we'll have to move on, and the next case presenter will be by Dr. Chu Ai Sun, and he's working in KPJ Seremban, Malaysia, and he's going to share with us a case on bifurcation stenting mix made easy with Create. Sun?
Yep. Thank you, Dr. Rosli, and good evening, everyone. So I'll be sharing the second case. The title of my case is Bifurcation Stenting Made Easy with Create. Okay, so just want to showcase why Create may make things easy when doing a bifurcation. So I have a case here, a 54-year-old male, underlying hyperlipidemia, but stopped medication for the last 3 years. He's a non-smoker. He has chest pain onset.
Sorry to interrupt, you need to share a screen, I think.
Okay. All right. Oh, I thought I started sharing the screen here.
No, we didn't see.
Yeah, can you see that? Yeah.
Yes, perfect.
Yeah. So he has chest pain onset at 3 hours, associated with sweating, giddiness, and shortness of breath. He was admitted to the general hospital here and treated as anterior myocardial infarction. So initial ECG showed ST elevation at V1 to V6 and 1 LVL, extensive anterior MI, and he was successfully thrombolized with IV tenecteplase. He was subsequently discharged at day 5 and recovering from cardiogenic shock with hypertension episode. And then he came to my clinic at day 6, 1 day after discharge. So on examination, his blood pressure is 98/60, pulse rate of 90, and SpO2 of 97 at room air. Systemic examination is unremarkable. He's not in heart failure. This is a ECG, show established Q wave in 1 AVL as well as V1 to V2. So investigation show that the echo, the left ventricular ejection fraction is 45%, severe hypokinetic anterior wall. The troponin at day 6 is still high, 2.74, and CKMB is 31. His LDL at admission was 5.7, and subsequent repeated is 3.6. Triglyceride is 1.7. So I proceeded with diagnostic angiogram on day 7, the next day, with a radial approach 6 front sheets. This is the RCA. Looking in the RCA, dominant RCA with the proximal to mid lesions about 70% stenosis. And this is the left system. Left system show epicranial wheel bifurcation lesion at the proximal LAD with the diagonal or significant diagonal. The diagonal is as big as the LAD. And the initial shot show that there is also some residual thrombus at the proximal LAD, if you can appreciate that, a bit of haziness over here, as well as at the ostium of the diagonal. And there is subsequent lesions at the mid-LAD, continuous from the proximal lesion. Further view showing a significant lesions at the proximal LAD and bifurcation, as well as over the mid-LAD here. So circumflex lesion show minor disease, about 30%. So the proximal LAD lesions is not up to the ostium. Ostium is quite free. So we know that there is a landing zone over here, avoiding the ostium LAD. So essentially, I have a case of a bifurcation lesion, LAD diagonal, Medina classification of 1-1-1. And there is a bit of residual thrombus both in the proximal LAD as well as the ostium diagonal. So what is the best approach for revascularizations? Okay, we'll put it to work over here. The first option will be antithrombotic medical therapy, and then come back later again because it's residual thrombus. B, PCI with 1 cent strategy, or PCI with 2 cent strategy. Yeah. So all the participants, please vote if you can.
So let's give us about 10 seconds.
Yeah. So we have a pool here. Yeah. So well, great. Yeah. So 59 of all the participants choose a 2-strand strategy. okay, whereas 29% say that one stent strategy would be adequate, and yep, 12% choose to a medical therapy. Interesting, right? So let's go through some of my thoughts here. Okay, so we know that Dr. Chen Xiaoliang have come up with a definitions criteria for bifurcation stenting, whether it's a left main or non-left main, okay, published in 2014. So have used this criteria to classify it into a simple bifurcation or a complex bifurcation. So my case here, I have a non-left main distal bifurcations. So the side branch is more than 90%, as well as the main is also more than 10 millimeter. So I have a major criteria, and I have two minor criteria here, whereas there's a residual thrombus in the lesions and the main branch lesions length is more than 25 mm. So I fulfill the criteria of one major criteria plus two minor criteria. So it would be a complex bifurcation lesions. And through this definition criteria, it has put to testing the definition 2 result published just recently in June 2020. It said that a 2 systemic stenting has a less rate of 1 year TLF for patients with complex bifurcations approach rather than provisional approach. Okay, this is because of a fewer TV myocardial infarctions and TLR. And surprisingly or not surprisingly, the incidence of stent thrombosis is comparable within these two groups, whether you do a systemic 2-stent stenting or 1-stent approach. Okay, but bear in mind the 2-stent approach mainly used approach here is TK crush, most commonly used 77.8%, whereas in the provisional stenting, the TAP approach has been mainly used. Okay, so we know that in COBIS registry, independent predictor of side branch occlusions, we have a case here, the probably diagonal, the main vessel is about 2.5 mm and as big as the LAD. So there is a big myocardium that I need to preserve. So independent predictor of side branch occlusions, I do not want to lose my side branch. So I know that my side branch is more than 50% stenosis. My main branch is also more than 50% stenosis. These are all independent predictor of side branch occlusions, losing a side branch. And the side branch length more than 10 mm and presence of acute coronary syndrome, especially thrombus. And of course, the left main lesions losing the main occlusions would be an independent predictor. So with that in mind, I have chosen a 2-stent strategy. Okay, so I've chosen 2-stent strategies. I use a EBO 3-5 approach using a 6 French and wire down to both the diagonal as well as the LAD. All right. So you can see here, which is here clearer, there is a bit of haziness. You can see a thrombus, a residual thrombus here, more clearer after the wiring. Okay, and if you notice here at the mid LAD, okay, notice once after wire, the LAD has become much smaller. Okay, so initially I thought it's just probably spasm. So I proceed on with the post-dilatations at diagonal 1. All right, the D1. So using Ikatsuchi 2 times 10, go up to 40 atmosphere. And then subsequently using a Ikatsuchi 2.0 dilatations at the LAD lesions. Okay, from over here, the lesions over here up to the proximal. And this is what it looked like post dilatations over the LAD and diagonal. All right. So at this point of time, the patient complaining of some left arm pain, probably spasm, I thought, but the BP actually dropped to, initially starting BP was actually 100. The systolic pressure was 100/60. Now the pressure is 80/53. This is after the dilatations of both the diagonal and LAD. All right, so a quick check over here. The LAD shows still very small. Okay, so in fact, what is happening here? Patient do not have any chest pain. The SpO2 is clear. He's not in failure. All right, just that the BP is slightly low. So at that point of time, I started on dopamine. To push up the BP. But at this point of time, I would like to ask, what is the cause of a mid-LAD lesion? Okay, can we put it to vote? First, myocardial bridging. B, atrial spasm. C, plaque migrations. And D, artery dissection.
Okay. Seconds.
Yep, we'll see the result soon. Can we have the pool result? Okay, so majority, about 50%, say that probably artery spasm. Okay, so right. So that is my initial thought as well. So I continue on after starting on this patient on dopamine infusion. So I proceed on with a stent placement with a create EVO 2.5, 13, went up to 16 atmosphere. Okay, so with a balloon over the main branch for crushing purposes. Okay, so I would like to highlight as well the create have two marker, one proximal marker and distal marker. So the distal marker, I like this because I can adjust exactly at the ostium of the diagonal. All right, and then the this is just to show the marker again. This is a balloon marker, and then this is the create stent marker. Okay, all right. So the balloon went up to 16 atmosphere at diagonal, and then subsequently crushing it with a Ikatsuchi 2010 at 20 atmosphere and upsize it to 2.515 at 14 atmosphere. At this point of time, because I want to save the procedural time because of patient hypotension, I have changed my strategy from DK crush to just a mini crush. And then after stenting to the diagonal and crushing the diagonal, I have proceed with a LAD standing at the main branch with a create EVO 2.540 at 16 atmosphere, right? So I've chosen a long stent just to cover the mid part over here, the significant disease at 80% stenosis, which I post-dilated, right? And then checking at the cranial wheel as well as the caudal wheel, okay? The stent marker over here and the balloon marker is over here, all right? So it's always need to know the stent marker is, the balloon marker is proximal to the stent marker, all right? And then subsequently, the balloon was up to 18 atmosphere. And this is what it looked like after stenting both to the diagonal and the LAD. And subsequently, I do a wire exchange. And you can see here with the mini crush and both the stenting, the wire can cross much easily, okay? So with the BMW wire crossing at the distal stent struts and exchanging from the side branch wire to the main branch. Yes, this is just a showcase how easily the wire can be crossed over or create at this point of time. And I proceed on with the post-dilatations, crossing a balloon 1.5 10 Ikatsuchi over the side branch and dilated up to 20 atmosphere, and using a subsequent 2.5 balloon to dilate the main branch as well as the diagonal branch. And I finish off with the final kissing balloon with a 2.5 10 and 2.5 15 mm over the side and main branch. This is the final kissing balloon, and this is the final result. Right, so I pull back all the wires. Okay, in between that time when the wire exchange, I also did a shot, and the mid LAD also looked as the final shot as this, with the wire being pulled out. So if you can appreciate, I think apart from coronary spasm, which initially I thought there's also some sort of a bit of myocardial bridging over here. All right, I don't see any further dissections, and the myocardial brush is quite well, and the small branches are all preserved. Yeah, so this is the final mid LAD, which I thought I would just show a bit of bridging over here, and this is, you can appreciate over the pre and post angiogram. Yeah. So the patient was discharged well after weaning off the IV dopamine after 3 days. And I'm planning to bring him back for re-angio again, as well as staging him for the RCA lesion. Okay. Yeah, with that, I thank you.
Well, Sean, thank you very much. That was a nice demonstration of the case. Of course, there might be some differences, but the myocardial bridging is something that you and I'm sure, would have seen from time to time, and especially when it's severe stenosis or even CTO. And once you have done and open it up, and especially get good flow, then the myocardial bridging actually comes out. And this sometimes can be difficult, especially in deciding, whether to treat a lesion or not. Any comments with regards to that point first?
Well, it's an interesting case. Did you think about imaging it? Did you do an IVUS to see what's going on distally?
Well, unfortunately, in my center, we only have IVUS if we pre-order it. So this is an ad hoc case, so I do not have any IVUS imaging at hand at that point of time. Yeah.
So, I mean, obviously that would be helpful to know. I mean, I think it probably is a bridge, but one thing you always worry about is an intramural hematoma that's extending. The fact that it didn't get worse over the course of your procedure makes a bridge more likely. But that would be one concern that one would have.
Also agree that this is a tricky case in terms of diagnosis. Not easy to really know what happened, but basically the final result, that's what counts, and the patient's outcome. So we don't always fully get the point of what's going on. And the bridges, of course, we know that bridges are prone to perforation. So we are always very reluctant to be enthusiastic with metal in severe myocardial bridging. I think you all have the same experience of causing perforations in these cases.
But this patient as well, he's very prone for spasm. Yeah, with the radial artery approach at the end of the procedure, he has severe pain over the radial artery, and there was severe significant spasm. Yeah. So with the wire insertions, initial wire insertion is also show that it's like grabbing the wire. Yeah. So I have tried giving a bit of IV GTN, bearing in mind his blood pressure is slightly on the lower side with dopamine infusion. So with the IV GTN, it has not really released the spasm as well if there's concomitant spasm with bridging.
Okay, I'm going to put up a question that was asked by a participant, which is why not one stent strategy? Would anyone do a one stent strategy in this case, the panelists?
Hi, KK here. It looks like it was a great case, and I think that choice of a two-stent technique is what I would go for too, given the size of the diagonal. So I wouldn't. I mean, I think a one-stent technique is reasonable if you have other reasons for minimizing, say, the duration of antiplatelet therapy. Mm-hmm. So if, let's say this was a pre-cancer surgery patient, and you just want to get the patient to surgery, then maybe you would consider a one-stent strategy just to minimize the duration for DAPT, even though there are stents now that are 1 month DAPT. But I think in this case, it's probably, all things being equal, better to do a two-stent strategy.
You don't want to lose the diagonal in this patient. That's certainly a point to make.
Yeah, agreed.
I mean, to me, if let's say you want to decide on the one stent strategy, you should at least ensure that the threshold for putting in a provisional stenting is actually low. So if you've got to really protect the wire, the side branch very well, because otherwise, if you lose that side branch, that's going to be such a shame. So and if let's say if I were to do a one stent strategy in this case, then this is a tendency for me to try to ensure that I open up the side branch well, and I would use a drug-coated glue in this case.
Mm-hmm. Yeah.
Okay. Would anyone think about doing a pot and making the blood vessel proximal to the diagonal bigger, and not just with kissing it 2.5 Are you comfortable with it?
Retrospectively, I think a pot will be great for the proximal vessel to open up further. Yeah.
We do that always. Yeah, not touching the bifurcation, of course. Yeah. But of course, you need to have space, and you need sometimes very small balloons, 8mm balloons, to do that, because you don't always have the space to pot properly. Proximal.
Okay, I think thank you very much for the case, Waisun. We now move on, and of course, the last will always have to be Fahim. And Fahim will discuss about a case creatively tackling 2 bifurcations in one very sick patient. Fahim.
Thank you, Rosalie. Hopefully this won't be too boring. It's kind of, this case is on the theme of what's been presented already by all the previous speakers. So, hopefully there'll be some learning points, at least for the younger audience. To go forward, this, don't have any disclosures. This is a young guy, he's 48. He has nothing much in his past history other than maybe his mom had coronary disease at 50. But he's known to have hyperlipidemia. He says that his cholesterol was around 300, which is about 8 millimoles per liter in the other units for about 5 years, but he's not been on any therapy. He came in with a funny story of syncope. He kind of fell down and then he had chest pain. He was brought to the ER, his CT brain was negative, and then he had an EKG which looked like this. Q waves in the inferior leads with some inferior ST elevation, but then also stuff on the lateral leads, and maybe something in V1, it's hard to know. Because he was having ongoing symptoms, he was brought to the lab as a, quote, inferior STEMI. And by the time he hit the lab, he was already on a low dose of inotropes. He was on, some norepinephrine for a low blood pressure. And this is his left coronary system. So, the circumflex is subtotal. You can see the LAD looks like a string. I'll show you another view. It doesn't get any better. That's the LAD with a diagonal coming off, and that's the right coronary artery. So let me ask the audience and the panel, what would you do next? And maybe if you can have the poll question. Would you fix the right? Would you fix the circumflex? Would you fix the LAD? Would you fix it all, or would you just put a balloon pump and go home? So we'll wait for a couple of seconds for people to answer.
F, E, and E.
So maybe if people have voted, can we have the result? So an interesting mix. So we have very few votes for going home, which is kind of a good thing or a bad thing, I don't know. But a lot of you thought about the RCA. So, my thoughts were at this point was, I really didn't know what the hell was going on. I thought, well, there's inferior ST elevation there, but there are Q waves. The right kind of looked chronic, but there were also lateral changes. So I really didn't have any idea what the cause was. But like many others, I kind of thought that the right would be the first thing to sort of tackle. And so went in with, this is right radial approach, JR4 guide, put an XTA in the right, didn't go anywhere, then put a Gaia first and then a second, and it really didn't go anywhere. And it felt very gritty and, crunchy, and it looked really chronic. So I then went back to the left side, this is again, 6 French XB3 guide. Notice that heparin's been given by this time. And if you look at the circumflex, it looks a lot, at least considerably better than what it was when we started off, suggesting that maybe this is the culprit, which, would have fit with the lateral changes on the EKG. And if you look at it here, these are sort of similar phases in the injection. This is before, not much is filling up on the circumflex, and this is after heparin. Now, of course, that doesn't mean a whole lot, but certainly it made me think that maybe the circumflex is the culprit. I have to say that I went with a hydrophilic Sion black wire, and you can see sort of, there's a timer on the right side. I wouldn't bore you with the whole painful details, but it wasn't easy to wire this. It took a fair bit of effort. So, for an acute or a relatively acute lesion, this didn't behave like the classic acute lesion. It behaved more like an acute and chronic. Again, for fellows in the audience, you'll sort of see, you just have to persist, let the wire find its place without, poking too hard. And then you'll see in a second, with the last sort of test injection, the wire sort of finally found its place right about there. So it was not an easy vessel to wire for sure. The side, the main circ was even more difficult to wire. I had to put in several bends to cross this with another wire. And this is what it looked like after dilating this with a 2-O balloon. And at this point, the patient continued to be unstable. Blood pressure was borderline. He was restless. So even though I would have, a young guy, 48, I would have wanted to think about a 2-stent strategy. I thought that at this point, just being conservative was the right choice. And so the mid-distal cert, I took a drug-coated balloon, which, as you can see on the right side, wasn't so easy to advance. And again, for fellows looking at this, you have to sort of have slow, gentle pressure, persistent pressure, let the balloon find its way down to the target vessel, and the balloon finally went. And then on the left side, you see this is after dilating the whole distal cert with a couple of drug-coated balloons. So at this point, I decided to secure the circumflex into that large OM, and this is a 3/0 by 48 create. Again, finds its way quite easily into this vessel, and then the stent was deployed, post-dilated, and after a pot, we did a final kissing balloon into the distal circ, and this is what it looked like on the right side. Fairly reasonable expansion of the stent and fairly good flow in the distal circ. And by this time, the patient's chest pain was considerably better. And I put in an IVUS at the end just because I, wanted to know that I've done the best possible job. And the stent data, as you can see, 6.75 distally, about 10 in the middle, and 13 proximally. The proximal circ I specifically looked at carefully, just anticipating that we may have to do something there later on. And it had plaque. The plaque burden was not huge, so I would say it was modest disease. But nevertheless, there was some disease over there. And the left main had quite a bit of plaque in it. So, and that's another look at it. So at this point, then, the guy is doing better. And so the big question comes is that, what do you do next? What's the next step? And his chest pain gradually settled. He gradually came off the inotropes, but he did develop acute kidney injury. His bloods showed that he had an LDL that was a whopping 7.5, which is 285 milligrams per deciliter if you're into the other units. And his creatinine was still considerably elevated, about 200, and his EF was 25%. So, young guy, 48, we felt that it was reasonable to offer him cabbage, at least, consider the option of cabbage. And he flat out just declined it. And the surgeons weren't that keen also because of his ejection fraction and the fact that the LAD just looked like a horrible vessel. And so after about 5 days, he was brought to the cath lab to fix the left main and LAD. And so here we are, right radial approach, 6 French guide, XB3, the Adroit 072 lumen guide. And you can see that the LAD continues to look pretty awful, I must say. This is the first thing you notice is that the LAD angulation is really, really sharp. It's a really odd takeoff from the left main. And so we tried to wire this with an Fielder XTA wire and a regular microcatheter. And you can see on the right panel, the angulation is very sharp. So the wire, as you can see on the left, would engage the LAD, but then would just plop right out. It would just prolapse out because of the sharp angulation. So at this point, I took a supercross microcatheter. And again, for fellows, I will play this whole wiring process, in full. The supercross is an angulated microcatheter, as you see on the right side, with a 120-degree angle. And you can see that, it was made wiring this angulated LAD very, I wouldn't say simple, but made it considerably easier. And you can see in the Fluoro store that I engaged the LED now, and then with a little bit of effort, it took about 30 seconds to get this whole wire down. The wire finds its way into the LED and then made its way through. So the Supercross really facilitated what would have otherwise been an impossible vessel to wire. After dilating the LAD with some small balloons, you can see that the LAD is diffusely diseased. But I thought that somewhere around here, there was a landing zone, and we did an IVUS to confirm that. And of course, the whole LAD was diffusely diseased all the way to the ostium, and the distal left main also had some disease. So here is a Create 25 by 46 long stent going in. And again, for trainees and younger interventionists, the trick is to sort of have slow, consistent, and continuous pressure on the stent as you kind of push your guide back in as it gets disengaged. And you notice that the stent, went in with relative ease. I wouldn't say it took, this is a long stent, diffusely diseased vessel. Normally, this is quite difficult to do, but it went quite easily. and the stent was then deployed. And then the question comes is that now what do I do? Do I do a provisional approach across the circumflex? The ostium of the circumflex isn't really that bad, but it's not totally normal. Or do I do a DK crush? And the thoughts that occurred to me was what you just heard Dr. Chu talk about, the definition 2 trial. Now, this patient doesn't fit the definition 2 criteria. The circumflex lesion is not that complicated, but it's not all that normal. And my thoughts were, this is a young guy. I would like to secure his anatomy as best as I can because he's not going for surgery. And so I decided to adopt a DK crush approach. And this is a 3.5 by 13 create in the circumflex with a 3.5 NC balloon across the left main into the LAD. And what I'd like to point out, if you look at the still image in the middle, and the stent markers are marked in red, the stent balloon marker is in blue, and the stent marker allows you to position the stent right where the ostium is with as minimal as possible a crushing segment. And that's sort of illustrated again over here. The stent marker is in red, the balloon marker in blue, and you notice that the stent marker is right where the ostium of the circumflex is. The stent was deployed, and then on the right side was crushed with a 3.5 NC balloon after removing the circumflex wire. As Chiang said, you could possibly leave it there also. I usually tend to take it out. And then we did a pot crush. So when you're doing DK crush, it's important to not only crush with a balloon size to the LAD, like a 3.5, but then crush with the balloon size to the left main. Excuse me. And what I'd like you to do is focus your attention on the panel on the left, and you notice that the 4.5 balloon, the markers of the crush stent help you position the balloon at just the right spot for a pot. And you can see, here comes the balloon with its markers, and the marker touches the stent marker and sort of making your pot as precise as it can be. The pot was done, and then after that, that's just showing the same thing again. We went ahead and rewired the vessel, and you notice that when you're wiring the vessel, the stent markers come in very handy. And how, just as Chiang pointed out, that I'm in the stent, and if you look at the panel on the right side, I can see that I'm definitely in either the proximal or the mid strut, and I'm not in the distal, which is what you're trying to avoid. After that, we did the usual, sort of 3-step kissing, 3.5 NC high pressure in the side branch with the circumflex, 3.5 NC high pressure across, and then modest pressure 3.5 NC in both the LAD and the circumflex. Then the next step was to put in a stent in the left main LAD. Because there was disease in the left main, I decided to stent all the way to the ostium. And once again, the markers come in very handy. You can see on the middle panel, the stent markers is in red. The stent balloon marker is in blue. And I'm positioning the stent right at where the ostium is to cover both the lower lip of the ostium of the left main and the upper lip. And you can see that in the flow in the cineangiogram on the right side. And notice that I have a floating wire in the aorta to prevent my guide from getting sucked in so that I don't inadvertently cover the ostium and end up with the geographic miss. And this is sort of, if you look at the next picture here, you have your stent marker, which is in red, and it is just outside where the ostium is. So you have that 1 millimeter hanging in the aorta. Notice that the plane of the ostium is the white line, not the red line. If you park your stent where the red line is, so if the stent marker in red was at the red line, then you would miss the upper lip of the ostium of the left main. Then, after deploying the stent, did a pot with a 4.5 NC balloon, and then rewired the stent. And you notice that we go in with a loop and then come back and wire the side branch, so through the left main stent into the circumflex, and then went ahead and did another kissing balloon inflation, which should hopefully play there. There we go. So 3-step kissing balloon, again, high pressure in the side branch, high pressure in the main branch, and then modest pressure kissing. Post-dilated distally, and then finally did a repot proximally. The repot has to be proximal to the carina so that you don't mess up the bifurcation. And after all this, I'll show you hopefully the final shots right here, which if it would play, and I hope it does. Let me just try to go back. I apologize. Here we go. So this is the final in the caudal view. This is the final in the spider view. So quite a satisfactory final result. This is the final. In the cranial view, looking at the LAD. Looks reasonably good. There's a lot of distal LAD disease, but the septals are there, the diagonals are there, and you can see the right filling up by collaterals. I did do an IVUS also, and the stent landing zone was pretty good. About an area of 5 distally, nearly 8 in the mid, 11 to in the proximal, 17 millimeters square in the distal left main. And the ostium of the circ had a stent area of 9.25. So all pretty good by all IVUS criteria. And this is, again, the summary that this is what we started off before and after. Fairly, I would say, satisfactory result with the Create stent. So essentially this was 2 bifurcations. We had a bifurcation at the outset, circumflex obtuse marginal, which we treated provisionally with the drug-coated balloon because the patient was really unstable at that time. And then we had a left main circumflex LAD bifurcation, which we did with a DK crush when the patient was more stable. So at follow-up, he was doing well on a good regimen, and his numbers have gotten much better, including his cholesterol and his creatinine. And hopefully he'll continue to do so. We don't have follow-up ejection fraction yet. It's a bit early. So if I was to conclude, ladies and gentlemen, bifurcation lesions are common and challenging. And this is the case. This is a very sick guy. He's a young guy who came in with a lot of problems. The circumflex bifurcation was treated with a drug-coated balloon provisionally because he was unstable. And then the left main LAD circ bifurcation with the DK crush when he was more stable. I think specialized microcatheters, like I showed here, the supercross, can play a crucial role in complex interventions. To manage to wire the LAD. I don't think we could have done it with too many other options. Maybe a double lumen catheter like a Crusade or twin pass might have helped, but I think the supercross made it really easy. I think hopefully this case shows that a Create stent with markers can present some distinct advantages, which you saw over here for positioning and then for marking the place where you're going to do your pot and things like that. So it was quite helpful, I think. And of course, imaging, intracoronary imaging, I think is an essential component of complex bifurcation PCI, at least in 2020. Thank you very much. I'll be happy to answer any questions if they are.
Yeah, thank you very much, Fahim. It is not satisfactory results for him. It was an excellent result. I think we can clearly see that.
Thank you.
Any comments from the others?
Yeah, maybe have the others speak first before I give some points. Who else wants to comment before?
Yeah, I think congratulations, Fahim. Yeah, because it's a nice demonstrations of the markers, and you have even cartoon illustration on that, so that we bear in mind we will not miss the ostium. Yeah, thank you for that. Yeah.
Thank you.
Any other comment?
No, I think it's a really fantastic case. Very nice illustration, very impressive wiring. I think these cases are very, very difficult, and you have a fantabulous result. So congrats. I'm very impressed.
Thank you.
Any comment from you? You need to unmute. Yeah.
Yeah. No, I think I agree. It's a great case. I was just trying to understand, maybe because I guess I showed a similar one. When you stented the circ, right? You stented the left main into the circ. Sorry, this is for the left main bifurcation. You stented the left main to the circ, and then you crushed.
No. I did. I stented I did a DK crush, so I stented the circumflex, with a little protrusion, into the left main, then crushed it, and then stent the left main into the LAD.
Sure. And then after you crushed it, the stent marker, I would have thought, if you crush a Create stent, then the two, whatever side your marker started off, whether it started off at the top or whether it started off at the bottom, after you crush it, it will all be at the bottom on a caudal view.
if you have a huge, so if you're protruding a lot of it inside, then yes, both markers will essentially come together.
Yep.
But I think that this is where I think, and I was alluding to the question I was trying to ask you earlier, that it's essentially a micro crush. I mean, you really are protruding just a little bit in, and then when you crush it, you don't get a whole lot of movement. You just get enough scaffolding of the ostium that's just right. Now, will this work in every case? I don't know. But I think, we definitely covered the ostium because you can see that on the IVUS. The protrusion was just enough to, allow that so-called ideal minimal crush without having too much of mangled stent with the markers piling up on each other.
Probably all this depends on the size of the circ, size of the left main, size of the LED. The angle is very important,
yes,
of course,
yes,
because it will determine how,
sure,
once the balloon from the left main LED, how it will pose. Concerning the supercross oleo, so I find it a fantastic tool. I used it recently 2 times, and I had an LED with an extreme angle to get distally from the wire was always going to the diagonal, and basically I made a full 30-60 degree loop with my wire from the supercross. So the supercross is really impressive.
It is.
You can't use it you can't use to go distally because that's not made for it. If you're having a CTO, you have to trap. And what I learned from my limited experience with supercross in terms of trapping may be tricky in a 6 French guide. You have to be really careful because there's not much space with the supercross.
So my experience with the supercross is that when you trap it, at least with the earlier version, you would end up sometimes losing the wire. So now I just dock it. I dock the wire and actually pull it out the old-fashioned way, like an over-the-wire situation.
Well, what I do basically, when I put my wire in the second vessel, like in a diagonal, for example, then I will basically anchor on the diagonal wire. You see. That enables you to stabilize the whole thing. But really be careful with supercross in terms of traditional trapping because you may lose everything. You agree?
I agree. I agree with that. That's been my experience too, and we've used it quite a bit, and that is one caveat to it. So best is I find that just old-fashioned way: put a dock extension, extend the wire, and just pull it out the old-fashioned way.
Yeah. Okay. But the cartoons were great. I really. It was also really showing this typical aspect of the left main being the superior part rather higher and find the real right spot not to miss the real ostium of the left main is a very important thing. So that was a great case to end with.
I have a question for for Faima. I forgot to ask. Did you mention which wire you used with the supercross?
The wire was a Fielder XTA.
Okay, right.
Because essentially the LED was a functional CTO-esque vessel. So I find that in that situation, the 0.009 tip of the XTA is, or an XTR somehow seems to be work quite well for me.
Okay, Eric, we need to keep the time. I think we're going to go a bit of time if it's all right. So I would probably thank you very much for him for the great case. I'll probably try to share with you the practical approach of left main bifurcation stenting. I like lectures of this nature because at least it tells you that I can give my approach, and you may or may not agree with it. But this is something that I would do myself. Let me see now whether I can display setting and swap. All right. Okay. So I'm just going to share with you my approach to left main stem PCI, and this is a bifurcation PCI. I think you can. I hope you can see the screen. No. All right. No. Okay. My IT guy is actually holding this. Okay. Can you see the screen now?
Yes.
Yeah. Thank you very much. Okay, I think the first most important thing to actually assess when we have a left main stem bifurcation lesion is really to assess the severity for the intermediate lesions. I think on the left side, if you can see a picture on the left side, it's very clear that this is significant. No one will question that, and these are cases that have been shown just now. But when you come to cases like this, where it's like, you know, a borderline lesion, then one must make sure that it is a lesion that needs to be treated or left behind. And in this case, I would think that we will have to do an imaging technique. Most times are not for any borderline lesions. We tend to pull up an FFR. But for the left main, it's slightly different. I would pull up an IVUS first and then decide whether it's severe or not. And there has been a lot of data to suggest what is significant and what is not. Anything more than 6 mm squared shows that it is mild, and you should defer and not do anything with it because it is not significant. Anything less than 4.5, then is significant and you have to treat it. Now, in between 4.5 to 6, and if you're not sure, and this is where you're going to have to pull up an FFR to assess whether it's going to be a significant lesion or otherwise. So that's how I approach in a patient with intermediate lesion or borderline lesions. Now, the second thing that I would do is I would like to then assess the vessel involvement, whether it's just the distal left main or it involves ostial LAD or circumflex at the same time, because this will help to decide with regards to stenting strategy. And I think this has got to do more with whether it's a true bifurcation lesion or otherwise. And like Dr. Chu's patient lesion just now was, was showing the LAD in diagonal. So that's something which is also the same with left main stem. From there, I will then decide on the stenting strategy, whether it's going to be a single or a 2-stent strategy. And if I choose a 2-stent strategy, then I would like to decide what technique or which technique that I'm going to use. So in this case, it is also important, since if you have an IVUS, it is quite important because this will help to determine all the questions that you want to ask yourself in the beginning, the involvement of the ostium, the vessel size, the plug morphology, and therefore what sort of devices you're going to have to use to prepare the vessel, and in the end to assess the final results. Now, 1-stent crossover, especially if it's not a true bifurcation, is ideal because you do not have too much metal in it. Obviously, you need to protect the side branch with wire in case you lose that side branch. You don't have to do it in all cases, especially, for example, the side branch is not diseased or very minimal disease, then you may not even want to protect it. But I suggest for people who are in the beginning of doing left main stem bifurcation, you would want to protect the side branch, and at least you'll be more confident that you'll be able to salvage the side branch if it gets jailed. Now, the question is that final kissing post-stenting, if side branch is jailed, then it really depends. Once after you put in the stent, you find that there is a side branch which is jailed. Do you need to treat that side branch or not? I think it depends really on how large the side branch is and the severity of the jailed ostium. I tend to see also the flow, and some people actually pull up an FFR. But if I feel that the flow is good and the jailed side branch is not severe, I would tend to leave it alone. And if I were to need to think about kissing balloon, because sometimes, you find that you are concerned about the flow in the side branch being affected, and over time it might cause some changes and cause stenosis in the side branch, then I tend to use a much smaller balloon to open the side branch up. So final kissing with a side balloon in the side branch, which is small, just to ensure that I get the lumen or the stent starts to be open and ensure that the flow is going to be good. So that's how I approach with the 1-stent crossover. Now, with it, what is very important, as has been emphasized again and again, is a proximal optimization technique. You should think about pot, and potting all the time. And the reason why you want to pot it is because you want to ensure that the stent is well expanded and well opposed. And there also there are certain reasons and conditions that you can see that for soft plug, you can have some plug displacement to the side branch, and it will be much better for you to ensure that you pot. And once you pot, you can easily recross into the side branch. So that is something that you should consider all the time. Remember, pot and the proximal vessel to ensure that you get good results in the end. This is an example. This is given by Kang with, I know I've got some on my own. This is a pre-PCI that you can see the left main stem, the LED, and the circumflex. And this is what the pictures looks like. And most times than not, when you put in a stent across the left main stem to the LED, you find that there will be some change, conformational change to the ostium, the circumflex, and it makes it look as if it's pinched, but really there's not much of plug displacement. It's very minimal, and you can actually leave it alone confidently without having to treat and to put another stent in. So a two-stent strategy, to me, depends on the size of the daughter vessels and angulation of daughter vessels, and this has been discussed in great length in a lot of other meetings. But really, to me, the two-stent technique strategies that if you are wanting to perform, I feel that you should be comfortable about putting it. You've seen a lot of double kissing crush, and I think the data is very good with DK crush. But a tap technique is fairly simple, and you may want to consider that, and also pull-out technique. So these are the three stent strategies that I usually employ. But I would say that please learn 2 or 3 of them, and then use the ones that you're comfortable with. Of course, depending on the 2 factors, the size of daughter vessels and also the angulation of the vessels. Remember again, pot. Now, the other question that you like to ask is that, do we need to stent till the left main stem ostium all the time? Well, I would say that it's not necessary. But in this case that was just done last week, a CTO of the LED, and you can see that the left main stem is also significantly stenosed. This is a point that you should think about stenting onto the left main. And Fahim has shown very well how you should put a stent to the left main. And just a short video to show that an IVUS will be good. And this is a stent which is just into the left main. And you just want to ensure that you do not miss the ostium of the left main stem. And another lesion, and this is interesting because we've got 3 lesions in the LED, and I thought that it was not significant. And the QFR showed that the proximal lesion was significant. You have a bit of a distal left main stem in this case. And this was confirmed by an FFR. So if you can see that the left main body is quite good size. And so in this case, we just stented until the body, and we did not have to stent until the left main stem. So that is also, you don't really have to stent in all cases until the ostial left main. But if you were to do an imaging and intravascular ultrasound, that will give an idea whether you need to stent under the ostium or otherwise. A bit more confident in that sense. Do we need to IVUS all left main stem? I think a lot of panelists will probably say yes. Of course, IVUS, to a certain extent, OCT is useful in determining the significance of intermediate lesions. As we said, it is useful in terms of the planning strategy and the choice of devices. And it is also important in determining the optimal PCI results. So one of the things that you look for is optimization with regards to stent expansion and position. You look for complications, and you'll be able to assess the immediate and long-term outcome. You have seen this by Kang in a lot of meetings, saying that you should have a minimal stent area of 5, 6, 7, and 8. 5 in the ostial circumflex, 6 in the ostial LED, 7 in the confluence, and also 8 in the left main stem body. For Caucasians in the syntax study, they said at 7, 8, and 10, and truly because they are bigger size. But remember, these are alluding to a group of patients, and in Asians where the size of left main stem is actually smaller. But if you have a patient with a large left main stem and also LED and circ, you should aim for much better results as much as possible. Because if you know that you get good results, the TLR is less and also the MACE rates is less. And in the long-term results, we've used IVUS as one of the ways you want to assess results. It has also been shown that it can predict less cumulative mortality as when you use angiographic guidance per se by itself. So try to use imaging technique as much as possible, and to a certain extent, it's an essential obligation for us to actually do imaging technique when you deal with left main stem PCI. So to conclude, ladies and gentlemen, we've mentioned about all the factors, but the key question is when you treat, do you want to consider left main stem bifurcation lesions as in treating any other bifurcation? There's a yes and no answer to it. Yes, because the techniques are the same technique-wise, but no, because the implication with regards to outcome is different. Because left main stem, if you don't perform very well, then the risk of mortality is much higher during follow-up. You treat only if it's significant. This is where the imaging techniques are very important for intermediate lesions. Then you want to consider the stenting technique. To me, imaging is essential. But in the end, when you treat left main stem bifurcation lesion, you should try to aim for as near perfect or perfect results as much as possible, because this will determine long-term results on mortality. And you want to be as good as surgery in a patient with left main stem disease. So thank you very much, ladies and gentlemen. So that is something, my take-home approach with regards to stenting of the bifurcation left main. So Eric, back to you.
Yes, thank you very much, Rosalie. I think this was a great session. We have run 5 minutes over time, but I think we are used to running over time with webinars. I think I enjoyed a lot, and I think probably all of you panelists and speakers enjoyed the session. We have now get used to this Zooming activities. Although yesterday evening at CNN, I saw psychiatrist professors speaking about the risk related to Zooming conferences, because we are physically not, there is absence of physical emotional contact, but anyway, there's nothing we can do about it. We have to live with it for the moment. We are in the second wave, full in the second wave in Switzerland and Europe now. Our hospital has declared war on COVID this morning. We have locked down all active procedures. We can't travel anymore. There's no more education. There's no more elective activity again. And Europe is rushing into the wall again, much more than the first time. Of course, this is not related to this seminar, and I should focus back on what we discussed during the last 90 minutes. It was passionate, it was good, there was a lot of education, there were great cartoons. The cases were comparable to some extent, because we saw left main, we saw bifurcations, we saw some diagnostic and therapeutic challenges, and they were all clearly exposed by the speakers from the first to the last. Rosalie, who was making a general comment on the approach. So I propose to have a very short run across the different speakers. I would start with KK. Any comments, final comments from your side?
No, I think the session has been wonderful, and I've seen amazing cases from all the panelists and speakers. So I really learned a lot, and I think for me the marker as well as the side branch access are key useful features of the Create platform.
Okay, Chinchi, any comment from your side?
Yeah, we agree with that. Learned a lot also, complex cases from all the different operators, and the use of specialized microcatheters, use of rotational atherectomy. So definitely a lot to take away from this webinar. Thanks.
Okay, Chowai, any comments from Malaysia?
Well, I think the main thing about bifurcation is that we need to be familiar and also get used to one or two techniques that you're familiar with. Yeah. So this webinar is probably just an introductions or a continuous educations for many of us here to continue learning. Yeah. Thank you.
Okay, Fahim.
Yeah, thank you, Eric. Great cases. I learned a lot from all the cases presented, and I mean, I think it's sessions like these that we all give us the opportunity to learn more than we would normally do from our colleagues, and hopefully everyone's learned something from these sessions. It was a great session.
Thank you. So Rosalie, the final word is to you. You can conclude the session if you agree.
No, I will leave it up to you to conclude. I think, as mentioned, I enjoyed it. And I learned something that Singaporeans have got terrible disease. And Eric, what did you close it? Thank you, everyone.
Thank you. So thank you, Rosalie. So I'm honored to close again. It's always a pleasure to be with you. I'm really missing you, my guys, my friends from Asia. It has been my last trip to your region has been to sing live, and at least I have the souvenir of my friends from Singapore, because I really meet and miss you all, and I hope that we will meet again very soon, somewhere after the summer of 21. I hope so. I hope so. All the best to you. Have a good day, and have a good night and a good evening.
Thank
Bye-bye.
you very much.
Thank you very much. Bye-bye.
Thank you.
Thanks to Alvimedica for hosting this and for supporting
Yes,
this.
forgot to say so. Thank you for reminding that, Rosalie. Thank you so much. Thank you, Alvimedica, for helping us out. Thank you.
Stay safe, everyone.
Can we take a picture?
Yeah, of course.
Yeah, Colin, why don't you?
This is the new.
Give me a second. Give me a second. I'm going to take a picture right now. Okay, 1, 2. Cheese. Okay, got it.
You can see clearly now. Thank you.
Thank you so much.
Great song.
Bye, thank you very much.
Bye.
All right.
Thank you, everyone. Thank you.